So welcome back, everybody. I'm going to kick off the second part of the morning by talking about the management side of things. And I'm going to be talking primarily about the management of POTS, but much of what I'll say will also apply to the other forms of autonomic dysfunction that we talked about earlier, vasovagal syncope and orthostatic hypertension. And in fact, a lot of the treatments for POTS have been sort of hijacked from the treatment for orthostatic hypertension. So the aims of treatment in general are to reduce the triggers, narrow blood vessels, expand blood volume, and reduce the tachycardia. And sometimes several approaches are required simultaneously. And the aim of all this at the end of the day is to improve quality of life. And, basically, it's not always helpful to get too kind of focused on the tachycardia, because if you reduce it and the patient's actually feeling worse, then, you're not doing them any favors. So we've spoken about triggers a couple of times today, the sort of triggers that that the patient wants to avoid are drugs, particularly those that lower blood pressure or in POTS increase the patient's heart rate. Prolonged standing or sitting triggers symptoms. Heat vasodilates, it dilates the blood vessels, and that can exacerbate symptoms. And alcohol is also a vasodilator and can reduce blood pressure and make patients feel worse. And then heavy meals, particularly those that are full of refined carbohydrates, white carbohydrates such as white pasta, rice, cake, biscuits, pizza, that sort of thing. We usually recommend taking a very detailed history, because very often patients are not taking as much fluid as they think they are. We usually recommend 2 to 3 litres a day in an adult, more if it's a hot environment or if they're exercising. And in children, we recommend that they drink until the urine is a pale straw coloured. Because of their smaller size, obviously 3 litres might not be appropriate. We suggest a boost before rising, particularly for those patients that are very symptomatic in the mornings, because patients are often a bit dehydrated overnight. And rapid water drinking can help in an emergency. That's having a couple of glasses of tap water in quick succession. And within sort of 2 or 3 minutes, that will actually raise blood pressure and reduce the heart rate due to an autonomic reflex. It's helpful if patients sort of monitor their fluid intake, perhaps using a bottle that maybe has a litre or something like that in it, so they have a good idea of how much they're having. And there are some quite nifty apps available for use free that will help you to monitor your fluid intake throughout the day, and it can give you a little bit of a fanfare if you achieve your target. Unless it's contraindicated, we recommend extra salt. Usually an additional, most people have around 6 grams a day, and although that will vary from person to person. And so an added 6 grams of salt a day, which is 1 level teaspoon, and it's equivalent to 10 slow sodium tablets. You need to take care in conditions like hypertension, renal disease, cardiac disease, and children in particular are very sensitive to increased salt intake. And there's a little formula there if you do encounter children to work out how much added salt they should have. We often find that patients make significant adjustments to their diet. There's not an awful lot of research around this. Lots of things have been suggested: paleo diets, plant-based diets, FODMAP diets, dairy-free, and so on. But the majority of patients seem to find by experience that having small, frequent meals, maybe eating half as much twice as often, so maybe 5 or 6 meals a day. And again, like I mentioned earlier, having them low in refined carbohydrates. It's very important that patients pace their activities, and it may be helpful for them to have an activity diary so that they can relate that to their kind of boom and bust situations. And there's something called the spoon theory, where the person has a number of spoons throughout the day. It's a bit like their battery, and they have to if they use too much of it up at the beginning, then they've got nothing left for later on in the day. And there's some information about that on the Dysautonomia International website. They've got a page on their website about the spoon theory. Exercise, if tolerated by the patient, can be helpful, but you've got to remember, and I'm sure you're all aware, that post-exertional symptoms can be very severe, and in fact, they can make the patients feel unwell sometimes for several days afterwards. So in the POTS setting, you have to take particular care in the setting of long COVID and ME/CSF. Patients should have an individualized regime, and it's flexible. If they find that they get symptom exacerbations, they should go back to the level that they were on before. And we need to warn them that they may feel a little worse afterwards, or a lot, and that it may take between 3 weeks and 6 months for improvement. And those that want to exercise, it can be helpful to start with just resistance exercises, moving on to horizontal exercise, such as horizontal Pilates, swimming, recumbent exercise, biking, and then graduating on to upright exercise. With swimming can be very good because patients obviously don't have the challenge of gravity in the water, so they often feel more comfortable when they're exercising in the horizontal position like that, supported by the water. But what they have a really big problem with is when they get out the water. You need to make sure that the pool isn't too hot. And then it's useful for them just to have something to throw on so that they can, get home quickly without changing in a really hot changing room or having a hot shower afterwards. And it's important that they cool down after exercising before they even get out the pool. There has been some recent research on compression, and that confirms that it can be helpful in POTS, and it's already been recognised to be helpful in orthostatic hypotension. What Professor Raj and Kate Bourne found was that having full length compression, and in particular, it was the abdominal and pelvic compression, and that was much more helpful than just having, for example, compression socks. And having the full length compression, or even just pelvic and abdominal, reduced the patient's symptoms as well as their tachycardias. Temperature regulation can be quite challenging for patients, and we usually recommend that they dress in layers so that if they start to overheat, they can sort of take the top layers off. And there are some little devices available, such as cooling vests, and you can get cooling towels that just work with evaporation, but they don't actually feel too wet when you drape them around your shoulders. This image shows postural maneuvers that have been used in orthostatic hypotension, and you can see here that when the legs are crossed or a leg is elevated to prevent pulling, patient squats down or elevates a leg when sitting, that this raises their blood pressure. But these maneuvers also reduce the tachycardia in POTS. And for those of you who are seeing young patients who are perhaps studying, it can be helpful to advise them to do this with their legs elevated, because that can reduce symptoms when they're studying. For emergencies, there are little portable stools available. Some of these are so small that they can fit into a pocket or a handbag, and can be sort of produced quite rapidly when the patients feel lightheaded. But some of them, particularly the one on the right, do require a degree of balance for the patients to be able to use them safely. Cognitive Behavioral therapy can be helpful for the right patients. You can imagine that patients are quite resistant to being referred for CBT and it's completely understandable because they've often been psychologically labelled for their physical symptoms before they get their diagnosis. But if it's explained why you're referring them, and it may be, for example, to help the patient to adjust to living with a long-term illness, or it might be to help them manage what are very real and scary symptoms, then it definitely has a role there. Now, we would normally recommend that patients would try these lifestyle measures for maybe around 3 months, sometimes even 6 months, before considering introducing medication. But there are some fairly severely affected patients who can't engage in some of the things that I mentioned earlier until they've had medication to relieve their symptoms. And medication generally is aimed at improving the blood volume, narrowing blood vessels, and in POTS reducing the tachycardia. And you can see on the right-hand side that there's quite a lot of overlap there with the medications that are used in orthostatic hypotension.